you can go ahead and get started.
Today, I'm pleased to introduce my friend and colleague, Ann Cross. I'll keep my comments brief because I know you'd rather hear her than listen to me. Ann grew up in Alabama and graduated cum laude from the University of Alabama School of Medicine. During medical school, she became interested in neurology, an interest that was driven in part by an illness in a family member. She did a neurology residency at George Washington, followed by fellowships at NIH in neuroimmunology and at Albert Einstein in neuropathology. She's been on faculty at Washington University in St. Louis since 1991. She received a Harry Weaver Neuroscience Scholar Award from the National MS Society and has been the recipient of multiple research grants, many from NIH or the National MS Society. She was awarded the John Distel Prize in 2019, which is a joint MS Society and American Academy of Neurology Award for outstanding contributions in research in understanding, treating, or preventing MS. Finally, I would like to recognize what an extraordinary colleague Dr. Cross is. She's a world authority on B-cell functions in multiple sclerosis. More important to me, she's a great source of scientific and clinical advice and an outstanding teacher. Our own Dr. Chen did her fellowship with Ann in St. Louis. It's a privilege to have her giving grand rounds today. The title of her talk is COVID-19 and multiple sclerosis, which of course is very pertinent to what we're dealing with these days. So with that, thanks Ann for virtually visiting us out here, and I'll let you get on with your talk.
Thanks so much, Jim. That was a really nice introduction. I really appreciate it, and I truly appreciate being invited to give this talk, and I wish I could be there, maybe in the future. So I'll go ahead and share my screen, and hopefully you can see this. Can you? Hopefully. So this is my talk, and these are our learning objectives, which you have, I believe, in your handout. But basically, this talk is going to be about multiple sclerosis and what effects COVID-19 has had on people with MS, and what disease-modifying therapies have done in terms of altering the course of COVID-19 in people with MS, and also the responses to vaccinations against COVID-19, what disease-modifying therapies have done to alter those. So at least the last two learning objectives may apply to more than just the MS field. So at the beginning of the pandemic, we were all, as you recall, very, very upset and not knowing what to do. And of course, we were had a complete lack of information in terms of what COVID-19 infections would do to our patients with MS, as well as other diseases. And so there were a lot of physician-based registries, as well as at least one patient-based registry that were initiated around the beginning of the pandemic to try to acquire as much information as possible. And I'll discuss several of these registry data findings, but particularly focused on the one called Covet MS, which is the North American registry. And this registry was developed to focus on North America because we have different types of people than other parts of the world, and different behaviors of our people. And we wanted to mainly answer those two questions, which were how do MS patients fare, and how do individual disease-modifying therapies affect outcomes of COVID-19. And we asked that healthcare providers enter information, not patients. The information was made to be relatively simple, but particularly it was de-identified, and at least at Washington University and many other institutions, it is IRB exempt, which of course eliminated a lot of regulatory problems and work. And we designed it to be rapidly entered. So, once one is familiar with the questions that are going to be asked, it takes less than 10 minutes to put a patient's data in with the chart in front of you. And it opened up for patients on April 1st, 2020. And I'm going to present data that's 18 months in duration out to October 5th, 2021. So the existence of the COVEMS North American Registry is due to this person, Dr. Amber Salter. She was at Washington University when it started, but she has since, sadly for us, moved to University of Texas in Dallas, and she is a biostatistician. These people below her name are the people who are on the scientific advisory board of COVEMS, and this registry was and still is ongoing, supported by the consortium of MS centers, the MS Society of Canada, and the National MS Society of the United States. And our first two papers below are shown. So data collection, as I mentioned, would be by healthcare professionals, not by patients. And the patients had to have either confirmed or suspected COVID-19 infection or a positive test. So they could be asymptomatic with a positive test as well. And we have numerous patients entered that are in that category. We wanted a minimum of 7 days and sufficient time to go by so that we'd know what the resolution of the disease would be, whether the patient would recover or perhaps die. And the important thing to know is that you can get summary level information anytime, real time, daily updated. If you go to this website here, it basically just covems.org, and you can find it. And you don't have to enter data to be able to see the results. And so this data is all kept at Washington University, where I am on a very HIPAA compliant REDCap database. So initially, the questions that were going to be asked had to do with demographics of patients who were entered, sex, race, age, cigarette use, other things, and then comorbidities, because even by early April, we knew that comorbidities affected the outcomes of COVID-19 in the general population. So all of these were acquired. And then clinical characteristics of patients, and in particular, their disability related to their ambulatory status. What drugs they were using was a very important question, of course, and included the drug that they were on prior to the present drug. And then as of April 27, 2021, questions were added regarding patients' vaccination status. If they got COVID-19 in 2021, had they been vaccinated? What was the time period after vaccination? Which vaccination did they get? And then, of course, the outcomes were important. And that was, whether they had a good outcome, so they were not hospitalized, or they had increasing severity of bad outcome, hospitalized or admitted to the ICU, and or on a ventilator, or they died. So here's what we had as of October 5th, 2021, entered into the database, over 3,400 entries. Now it's well over 3,600 and 88 deaths. And as you can see, most of the data comes from the Northeast and the South, with the Midwest and West a little bit lower, but really from all over the country, as well as Puerto Rico. Canada contributed 146 cases. We have 2 cases from Mexico as well. This is what you would see. I'm sorry for this being so light, but this is, if you go into COVEMS registry, you will you can see the current data by clicking on this area that's I've circled in blue here, and there's several pages of it. This is just the beginning. And then if you want to enter a case, you go over here where the red arrow is and enter your case. And we would appreciate any cases being entered because we're continuing to collect data and will until this pandemic is over. So as of the 5th of October, 2021, we have this 3,452 cases entered. And these are the general results of who's in there. Interestingly, these haven't changed much since January of 2021, prior to much vaccination. So 75% female, age, mean age of 47, but a wide range of ages. 68.5% non-Hispanic white, 17.6% Black or African American, 7.7% Hispanic or Latino, and then 6.2% other races. Disease duration is quite a large spectrum as well. And then most of the patients relapsing remitting over 80%, and that hasn't really changed. And most of the patients fully ambulatory, so not extremely disabled or disabled at all. So now the results, some of the results from the registry, we have seen that for every 10 years of age, that increases the risk of death by 87.5%. This wasn't a huge surprise, of course, because we knew that for the general population too at the time. The patients who were on an ventilator or ICU, in the ICU also was increased for every 10 years of age by 43.5%. Death was increased over 2 times for men versus women who were in the registry. And these are taking into account other factors as well. And in terms of race influences, we found that being Black increased the risk for being in the ICU or on a ventilator by 2.5 times. And that was statistically significant. It also increased the risk by 1.5 times of being hospitalized, but not statistically increasing the risk of death, although there was a clear trend. And being Hispanic or Latino did not seem to increase the risk statistically for death or ICU or ventilator status. Not surprisingly, maybe, being more disabled in terms of ambulation had a clear increasing risk for being hospitalized or on a ventilator or in the ICU or dying. I mean, you can see it clearly in this right-hand column where 14% of those who were non-ambulatory died, whereas only 0.6% of those who were fully ambulatory died. And most of them did very well, those that were fully ambulatory. And then those that walked with assistance were in between for all categories. So these are the proportion of people on each of the disease-modifying therapies or on no disease-modifying therapy in the database as of October 5th. And as you can see there, that almost 1/3 of the cases were on ocrelizumab that were reported into the registry, with another 15% that were on no disease-modifying therapy. So this registry is very much skewed toward ocrelizumab, and that may be in part due to market share. We were able to obtain the US market shares for these drugs as of February 2020, and at that point, ocrelizumab was 20% of the market share in the US, so this is not too far off, but a little bit higher. On the other hand, the market share for interferons was running around 14.5% as February 2020, and for glutamate acetate, it was almost 19%, it was 18.9%. But as you can see, they are much lower proportion of the disease-modifying therapies actually put into the Covet-MS registry. So we noted that and wondered about that, that discrepancy there. So here's some data showing results of what happened to people based on their disease-modifying therapy in the Covet-MS registry. And to try to show it, disease-modifying therapy category comparisons between the different types, this graph is meant to try to show that. And so the blue is people who did well, not hospitalized. And so for many of the categories of disease-modifying therapies, that's running around 90% or even higher. However, the orange is people who were hospitalized. The yellow, the far right bar, is people who died on that particular category of disease-modifying therapy. This is no disease-modifying therapy over here. And so you can see that rituximab is a clear outlier. Ocrelizumab is also somewhat of an outlier, and no disease-modifying therapy is another outlier compared to these over here and to nanolizumab. The proportion within each category of disease-modifying therapy that died is written above that gold bar, just because sometimes it's so small. And you can see that 3.2% of those enrolled in this registry died who were on rituximab, and 2.2% on ocrelizumab, compared to less than 1% for the interferons. And a much higher proportion of rituximab was reported as being hospitalized. So once vaccinations were available, we added questions on vaccinations. And again, that was put in on April 27th. And these data here are from the 240 people reported after that vaccination question went in and who had COVID-19 in 2021. So around 42% of the people reported where there was an answer to the question had not been vaccinated, and 41% had, so pretty even, but also 17% we did not get an answer to that question. So this is looking at the different therapies just to see if there was any difference in the proportion of people being vaccinated on the different therapies. And interestingly, there was for the sphingosine 1-phosphate therapies. So that's fingolimod and siponimod and ponesimod and ozanimod. The answer was the overwhelming majority of those people had been vaccinated based on this registry. And then, but then if you look at something like rituximab or ocrelizumab, it was about half and half for those two. So different proportions. And then over here for glutathione acetate, in fact, the vast majority had not been vaccinated. So you know, these aren't large numbers, and this could probably change a lot in the future, but we thought it was interesting and might bear on how to interpret results later on. So the next question we asked was, did having COVID vaccination seem to alter severity in the people put into this registry? And we didn't have enough numbers to really even address this for most of the therapies. But here you have vaccination no, and here you have vaccination yes. And at least for ocrelizumab, the numbers seem to be high enough to say that no, it did not appear to alter this severity. In fact, there was a slightly higher, but not statistically significant number of people who were, proportion of people who were not hospitalized in the non-vaccinated, so the good outcome, than in those that were vaccinated. And then we also looked at deaths, and this is actually up to October 15th, because we got another death in between October 5th and 15th and put it in here as well. And basically we wanted to ask here, who died who had been vaccinated despite being vaccinated? And so we had to have people who had COVID-19 in 2021, and the person entering their data had reported on their vaccination status. And we had 8 people who reported being vaccinated. Most of them were with the Pfizer vaccine, 1 person with J&J. And here's their age ranges. We didn't put down the exact age due to the fact that it could almost, with this few number of people, be non-HIPAA compliant. And so most of the people were women, but of course the registry is mostly women. Most of the people were white, and a couple were Black. And most of the drugs were B-cell depleting. We had 4 people on ocrelizumab plus 1 person on another B-cell depleting agent who died despite being vaccinated. Now, the time from the vaccination to developing COVID was not probably long enough to develop full vaccination response in 2 of these people, less than 2 weeks for this person on teriflunomide and less than 2 weeks for this person on ocrelizumab. And most of the people, but not all, had comorbidities as well. So now I'm going to show you a little bit of information from other databases around the world, including one large compiled database from all over the world. So this is the Italian MS Registry published report in Annals of Neurology in early 2021. And they reported on their experience in that early wave when everyone knows they had a terrible time with COVID-19. And they reported on 844 people, most of whom did not have laboratory confirmed COVID-19. Most were suspected cases and not confirmed, but they reported an overall mortality in their MS patients in this registry of 1.5%, so not too high. And actually, most were not on any disease-modifying therapy. 5 were treated with disease-modifying therapy. They, in general, noted a worse or more severe course of disease in those on anti-CD20, either rituximab or ocrelizumab. And they had an odds ratio of 2.37 of having a worse, more severe course, meaning primarily ICU, but also hospitalizations. And they reported on recent use of methylprednisolone being associated with a worse outcome, with an even worse risk than being on an anti-CD20. We also saw that in Covet-MS registry. I just didn't put that data in, but that was consistent with our findings as well. And then here is data from a combination of the Italian and French registries, 2 separate registries in 2 separate countries that have been going on about the same length of time. And this is only confirmed cases now. This is not suspected COVID-19. And here they're reporting on well over 1,700 people with MS who also got COVID-19. And again, you're seeing this, worse outcome, higher proportions of people who died or ended up in the ICU in people on anti-CD20. And again, coming up with this better prognosis in people on beta interferons compared to all the other disease-modifying therapies. So they found that to be statistically significant. They also found people on no disease-modifying therapy to have a worse outcome. And notably, the people on anti-CD20 agents in this combined French and Italian experience, those people had a worse disability level than those on beta interferons, just of note. This is from that same combined Italian and French COVID study showing that there was a 1.6 times risk for every 10 years older that you were for a bad outcome. They actually didn't totally specify what bad outcome was, but I am assuming that's either hospitalization, ICU, ventilation, or death. And then higher disability also confirmed a statistically significant increased risk, being male again, and presence of other comorbidities like hypertension or diabetes. And same study, the combined Italian and French confirmed, looking at disease-modifying therapies now, and comparing to other disease-modifying therapies, anti-CD20 confirmed a 2 times increased risk of a bad outcome if you were on that, and that was seen in both the Italian and the French studies separately, and then also in the combined data set. And being on a beta interferon conferred a statistically significant better outcome with COVID-19. And that was statistically significant in the Italian group, not quite in the French group. And then again, as I had mentioned, methylprednisolone, taking that in the prior month at high dose conferred a worse outcome in COVID-19. So again, these data were extremely similar to what we had seen in North America and what had been seen prior in the earlier Italian group. So now there's a paper in press in Neurology that looks at over 2,000 patients that came from around the world. And this is primarily coming out of Australia, but it includes the Italian and French and Scandinavian groups and the Covet-MS registry data. In fact, almost 50% of these patients come from the Covet-MS registry. So it's sort of duplicating in a way what's already been reported. But the thing to note here is that a large number of people were hospitalized, almost 21%, and 3.2% died overall. And I'm just going to have you hold on to those numbers because we'll compare that later to something else. So, and in that same, huge international compilation of registry data, again, comparing this time to dimethyl fumarate, as giving that a score of 1, ocrelizumab patients, so that's a B cell depleting agent, and rituximab, B cell depleting agent, those two were associated with increased risk of being in the ICU, for example, here, and almost 4 times with rituximab. So putting all the data together, still seeing the same sort of trend of anti-CD20 or B cell depleting agents conferring a worse outcome if you get COVID-19. So, sorry. Having a hard time getting this to go down. Let's try this. There. Okay, one of the questions we asked in the registry, the COVI-MS registry, is did the patient receive a SARS-CoV-2 monoclonal antibody to try to reduce the risk of being hospitalized or worse? So now we have available those agents like bamlanivimab, casirivimab, and imdevimab that are used either alone. Initially, it was bamlanivimab alone, and then later combinations of these drugs in outpatients with COVID-19 at high risk. And basically what we found was that 72 people at high risk with MS who got COVID-19, and it was confirmed by swab testing, received these that were reported in the registry, and none of them died, and only 8.3% were hospitalized. And then, so hearkening back to the 21% or so that were hospitalized in the international compilation of data. I don't think you can definitely compare those two, but it is interesting how big the difference was. And only 2 actually ended up in the ICU or requiring ventilation. So we use these monoclonal antibody anti-SARS-CoV-2 agents, now they're called the cocktail, quite a bit in our high risk, really in almost all of our MS patients if they get COVID as an outpatient, and if they live with somebody who has tested positive for COVID-19, they can get it. And then maybe we'll have some oral agents available soon, but these are IV. So I just wanted to mention, since I've been talking about all this registry data, the limitations of registry data, and they are many. And so the data that I've shown you is almost surely subject to a large amount of ascertainment bias. So people, healthcare professionals, voluntarily submit data on their patients. We would tend to guess that they're probably the more severe cases that are being submitted, but that may not be true. We don't have any denominators. The best we've been able to do with denominators is the market share data for the different disease modifying therapies. We can't control for the population behavior, which may be very different in your part of the United States than in my part of the United States, or how that population behavior may change over time, or with parts of the North America that's being looked at. And then of course, treatments for COVID-19 have improved quite a bit during the pandemic. And so that may change the outcomes as well. And we have seen that. We have certainly looked for that and seen a big improvement in outcomes in 2021 compared to 2020. And I'm hoping that Dr. Salter will put those data together and try to publish them. Of course, we've had virus variants change over time, and different, R naught values for the virus variants. And then as I showed you in one earlier slide, people who were on the different disease modifying therapies for unclear reasons, and maybe this is a fluke of our data and not real, took the vaccines against COVID at different rates, and that may have skewed our data. So the next set of slides are going to look at, do MS disease-modifying therapies affect the incidence of COVID-19? And I do think we have one really good study, thanks to Dr. Tony Reeder at University of Chicago, who looked at 25,000 electronic medical records data from MS patients who were taking a disease-modifying therapy. So these people in this particular data set were all on disease-modifying therapy. So we don't have people with MS on no disease-modifying therapy here. And also we have people who had COVID-19 symptomatic. So it doesn't include asymptomatic cases. And he used, again, dimethyl fumarate as a reference point for worse versus better outcomes. And so worse outcomes are to the right and better outcomes are to the left. Excuse me, these are not outcomes. These are incidence of COVID-19 in people on these drugs, not outcomes. So increased incidence of COVID-19 was seen in people on anti-CD20 agents in this electronic medical records data set of over 25,000 cases. 3.25 times risk of COVID-19 symptomatic in that group, whereas there was decreased risk of or incidence of COVID-19 symptomatic in those on glatiramer acetate, and by about half, and interferon beta had a strong trend toward decreasing incidence of COVID-19. And these data also have been adjusted for comorbidities and age and sex. So these figures take all of that into account. So he also noted that those on taking disease-modifying therapies with MS had an overall death rate of 3.5%, basically, which is probably not that different from the general population. So another question that the MS community would like to know is, does COVID-19 alter the course of MS? And probably we don't have a good answer to this yet, although there are several studies ongoing looking at this. But here's some data that I was able to find in the literature. There was a fairly large study out of New York City with over 400 cases from the early days of the pandemic. And they found that about 10% of their cases in MS patients had what we would call a pseudo-exacerbation, which is worsening of existing neurological symptoms. And they only found 2 cases where they felt that the person actually had true new disease activity. And interestingly, both were new onset sensory myelitis immediately after a case of mild COVID-19. Another study I found was a meta-analysis of 26 studies of people with neurological illness and COVID-19. And in those different studies, there were 13 MS patients reported, none of which had worsening or exacerbations after COVID-19. Then there's an Iranian study that looked at 56 relapsing remitting patients with COVID, and then they matched 69 relapsing remitting MS patients in their patient set that didn't have COVID, and looked at the annualized relapse rate and did not find any excess relapses in those on COVID. Although there was some differences, they weren't totally matched in that the COVID-19 patients were tended to be on stronger disease-modifying therapies. And then they looked at 6 months prior to COVID and then 6 months after COVID in those 56 relapsing remitting patients who got COVID, and found no difference in the relapses. So they interpreted their data as no increase in relapses after COVID-19 in their cases. But then there's a patient-reported study out of the United Kingdom asking over 900 people with MS to reply. Only 41% actually responded and did the survey. And a large proportion of those reported what they thought was an exacerbation in themselves. And that included about 20% who developed new MS symptoms, but this data is so different from the other studies, it's hard to know how to interpret it. And I think the answer is still really out in terms of whether COVID-19 alters the course of MS or whether it increases the rate of new MS initiation. So again, I would say that we need to wait on the answer to this question. So now I'm going to change gears a little bit and talk about COVID vaccinations and MS, and talk about what the National MS Society and the American Academy of Neurology are recommending, and also just the effects of COVID vaccinations on people with MS and disease-modifying therapies on vaccination responses. So in general, vaccines are thought to be safe in people with MS, and this is even prior to the pandemic. It was recommended that people with MS get vaccinated, but we did know that there was some decreased response in certain immunosuppressive disease-modifying therapy treated patients. In general, the National MS Society suggests that one use caution in vaccinating with live attenuated vaccines, because they do actually cause active infections in people, and infections have been at least associated with pseudo exacerbations. There is one very frequently touted study of yellow fever vaccination in MS patients. Yellow fever vaccination is a live attenuated vaccine, and in this really small study out of South America, they found an increased risk of MS relapses in literally less than 10 people. And that's been sharply criticized. And in fact, a retrospective study of yellow fever vaccine with a much larger patient number did not show a risk of relapse after that. But in general, we probably should be careful with live attenuated vaccines in general, which we're not dealing with in the COVID era. The immune system is sort of broken up into the innate and adaptive arms of the immune system. And the innate immune system is not really involved too much in vaccine responses. It's mostly the adaptive, which is the education side of the immune system, learning about a truly new or educating the immune system to see something so that it can respond. The only member of the innate immune system that really is involved is the dendritic cell, which picks up antigen from a vaccine and moves it into the draining lymph node and educates T cells by processing and presenting that antigen from the vaccine and presenting it to activate T cells. So I'm going to walk you through this a bit. I've had to learn a lot about vaccination responses during this pandemic era. And basically what is thought to happen is that the person is vaccinated, let's say in the deltoid muscle, and the dendritic cells in the area will pick up the antigen. And in the case of mRNA vaccine, it'll be protein that was translated in cells in that muscle and presented and given and picked up by the dendritic cell. And the dendritic cells are very motile, and they move that antigen and process and present it in the draining lymph nodes, so which would be the axillary lymph nodes for the deltoid. And there, in these lymph nodes, you also have B cells waiting to be educated and in germinal centers. And there's a lot of factors that can sway how you respond to a vaccination, including just precursor frequencies, such as for B cells that are there, or a competition with other antigens that might be being brought into that same lymph node, or cytokines being expressed there. So a lot of things can factor into how good the vaccination response is. But this dendritic cell brings the antigen in, processes it, presents it to the CD4 T cells. they can move in particular, the T follicular helper cells move and interact with B cells, which they cross-activate each other. The B cells, how do they get to see the antigen? Well, the antigen, that is not totally clear, I don't think, from my reading, but the antigen somehow ends up in the draining lymph node. It is picked up by cells that are called reticular cells, and they are also known as follicular dendritic cells, but they're not the same dendritic cell that we show here. They're a different cell type entirely. And they pick up antigen. They don't process it or present it. They don't have MHC class 2 on their surface. They pick up this antigen and they don't change it too much. And they put it in endosomes that don't break it down, and they periodically recycle it to their surface and present it to B cells. And then B cells have a B cell receptor on their surface that may recognize it. And then, of course, they can mutate when they see antigen and become even more avidly seeing the antigen. So this antigen may sit in that germinal center in these reticular cells and recycle antigen back to B cells periodically for quite a while. And then through these processes, memory B cells are created and memory T cells are created, and some of those memory B cells will differentiate into long-lived plasma cells. The long-lived plasma cells migrate out and go to the bone marrow, where they sit perhaps for an entire lifetime, and then the memory B cells stay mainly in a resting state in lymph nodes, and then the memory T cells that are generated move all over the body, including in the bone marrow. So that's the high-level idea of what's going on with this vaccination. Now, prior to, well, let me just talk a little bit about vaccine types and their immunogenicity. So prior to the pandemic, there were 4 types that we typically use: the live attenuated, which generates a really strong humoral and cellular response, and it generally confers long-term or even lifetime immunity. And these are things like measles and yellow fever, which I mentioned earlier, smallpox back when we used it. But then there's also inactivated whole pathogen, like the influenza vaccine that's given intramuscularly, or subunit purified antigen. That would be things like proteins or polysaccharides from pertussis or pneumococcus or hepatitis B, or toxins that are inactivated, such as from diphtheria or tetanus. And these 3 categories, the bottom 3, are poorly immunogenic, and they require adjuvants to be given along with the vaccine, and they often require at least 1, if not 2, boosters during, or even more during lifetime. So just different types to know about, but now we have other types. So now we have, the mRNA vaccines as well. And then how do you measure vaccine response? Another thing to keep in mind is that most of the time it's measured by humoral responses, and that can be either by measuring IgG antibodies to whatever you're being vaccinated against, or it can be this hemagglutination inhibition assay, which is used a lot for the influenza virus responses. And cellular immune responses like T cell responses to vaccines are not measured very much because they're hard to do. And for flu vaccine, we know now, I mean, the medical field knows now what level of hemagglutination inhibition is needed to confer good immunity. We don't have that kind of information quite yet for COVID-19. So then this slide is taken from a study written by my former fellow, John Ciatti. It was just a very nicely timed review of vaccine responses prior to the COVID era, and looking at what the effects of the disease-modifying therapies in that left-hand column have on vaccine responses over in the right-hand column. And the middle column here is mechanisms of action and immune system effects of the various disease-modifying therapy categories. So the categories on the left, and basically I've written in red which ones have reduced rates of response to vaccination. This is pre-COVID era. And that would be the sphingosine-1 phosphate receptor modulators and the anti-CD20 agents had already been shown to have reduced humoral responses, at least, to vaccines like flu vaccines. Of course, there was not much data on some of our newer drugs. For oral cladribine, Dr. Greg Wu, who's actually a colleague of mine at WashU, had done a study looking at quadrivalent influenza vaccine in a few patients and shown that there was no effect on humoral responses, despite what one might have predicted, but very few number of people in his abstract. So this is just another rendition of guidance for people with MS getting vaccines, which includes avoiding live attenuated vaccines in people who are receiving immunosuppressive medications. Probably not as important for people on immunomodulators like beta interferons or glatiramer acetate. And there's some timing information that's suggested for these, and most of this is in the package insert for the various drugs. But for drugs that are B-cell depleting, it's really advised that you give the vaccines a month or so prior to starting that, at least 2 weeks though. And in general, it is suggested that vaccinations not be done or given during a MS relapse. So here I'm just mentioning the different types of vaccines that are available, which you all know in the United States. I mean, the 2 mRNA vaccines and then the adenovirus vectored J&J vaccine against COVID-19. And all of them are directed against the spike protein and specifically the receptor binding domain of the spike protein, which binds to the ACE2 receptor, which is on like so many cells in the body, and just how they're given. And I guess the thing to know about the J&J vaccine is that the adenovirus is replication incompetent, so it cannot replicate. Some planned adenovirus vector vaccines not for COVID-19 actually can replicate, and which may continue to stimulate the immune system and could potentially be good, but this one does not. So this is these are data from a study in Israel. So Israel did actually almost like a study of their whole population with Pfizer. They gave the Pfizer vaccine very early to people in their population in December and January of 2020, January of 2021 and December of 2020. They vaccinated their entire adult population, and of course that included their MS patients. And this slide is just looking at side effects from the vaccination in people with MS from a single center in Tel Aviv when they got the Pfizer vaccine. And they're really no different from those that we see in the general population. I think of note was that they saw more side effects in people who were younger, less disabled, and were on treatment with immunomodulatory therapies or disease-modifying therapies. So that probably suggests that these people were having a bit more of a response to the vaccines in general. This is a little bit more important data, I think, or at least it has really driven a lot of conversation in the MS community. Also out of Israel, same group of patients, looking at the IgG antibody response, so the humoral response to the COVID-19 vaccine, the Pfizer vaccine, in people with MS who were either untreated, 32 people, or on oral cladribine, 23, fingolimod, 26 people, and ocrelizumab, 44, and comparing those to people who were healthy controls. And as you can see, so here's healthy controls, good IgG titers for most people. Here's the untreated MS patients, did fine. Oral cladribine, surprisingly, I think to some, had a good response. 100% of their people had humoral responses to the vaccine. But for fingolimod, only one person had a small humoral IgG response to the vaccines. And for ocrelizumab, a large proportion did not respond. And mostly when they responded, they had low IgG antibody titers. So this, of course, was very concerning to the MS community, and especially since so many of our patients have been on ocrelizumab and other B-cell depleting agents. So, I made this slide to summarize data from 3 studies that include that Israeli study, but also more data that's come out from Italy and the United Kingdom, looking at responses in people on these various disease-modifying therapy classes or categories like beta interferons, sphingosine-1 phosphate receptor modulators, et cetera, and whether they responded to the vaccines or not. And you can see here that, and I just put in red the 2 that did not respond. And that would be, again, the sphingosine-1 phosphate receptor modulators, with fingolimod being the major player in that group in these data, and then the anti-CD20 agents, which are primarily ocrelizumab and rituximab in these 3 countries' data. And all of those showed reduced responses, at least humoral responses, so IgG responses. Interestingly, normal humoral responses were seen in the oral cladribine treated patients in these studies so far, or at least relatively normal compared to non-treated MS. And then all these categories up here had vaccine responses to the COVID-19 vaccines. Some of these studies involve not only the vaccines available in the US, but also ones available in the United Kingdom, like the AstraZeneca. So this slide is from a study by Amit Bar-Or that just got published maybe a month or so ago in Nature Medicine. And so what he did in a relatively small number of people receiving Pfizer vaccine, looked not only at humoral responses, but really he and his group of colleagues at Penn delved into the T-cell responses, and they found some interesting findings that they did see this reduction in antibodies to spike and the receptor binding domain, but also memory B cell responses they looked at were reduced. They found that the time from the last infusion of the anti-CD20, if these were IV infusions, mattered, and also whether B cells were reconstituting or not really mattered as to whether there was a response to the vaccine in terms of antibodies and B cell responses. So this has led, at least in our group, to have us checking B cells in the blood prior to vaccination if we can, and we'd like to see 1 or 2% at least there rather than 0. Hoping that we'll get a little bit better vaccine response. That's just what we do at our place. There's no consensus on how to use these data, and it's not that many people in this study. He also found that everybody had a corona SARS-CoV-2 spike-specific CD4 T-cell response, but at lower magnitude versus healthy controls, and that those circulating T follicular helper cells, the T follicular helper cells are the ones that stay in the lymph nodes mostly and interact with B cells. They were reduced in those people who were on anti-CD20s, and they were correlated strongly with the lower levels of anti-receptor binding domain antibodies. But interestingly, CD8 T cells were actually increased in people who lacked the neutralizing antibody responses, as almost like a fail-safe antiviral response. So there's now been at least one other study that that did a similar study and found pretty much the same thing as this. So now I'd like to just summarize a little bit of what I've told you, and that is that registry data from North America and Europe suggested that older, male, more disabled people with MS have a worse outcome. In North America, Black MS patients had worse outcomes than white MS patients. B-cell depleting agents were associated with worse outcomes. There was methylprednisolone at high dose was associated with worse outcomes. And there were 8 deaths in people who had received COVID vaccination despite receiving COVID vaccination in our registry, most of whom were on B-cell depleters, not all. 2 were on sphingosine-1 phosphate receptor modulators. Glutamine and beta interferon, there's accumulating evidence that they may reduce the incidence of COVID-19 and lead to a lesser severity if you do get it. There's no evidence so far that COVID-19 itself or vaccinations leads to MS relapses, but probably they are associated with pseudo exacerbations. We're seeing, as mentioned, a reduced humoral response to COVID-19 vaccines in those people on anti-CD20 and sphingosine 1 phosphate receptor modulators. So I just want to have this final slide here showing that the registry is still open, and please enter your patients with MS or related diseases such as neuromyelitis optica into the registry. And even if they just have a positive swab test and no symptoms, we would like to have them in because we want to know, what happens with them. And you can see data from this anytime you go to this, just go to this website, you can pull down up-to-date real-time data from the registry. So again, thank you very much for having me. And I'll try to answer any questions if I can, if there's time.
Thanks for that great talk, Ann. There's a couple of questions that have come in. One was from maybe a third of the way through your talk. Dr. Kaikorabun asked about the people that had been vaccinated in the registry, whether we know whether they received 2 doses or 3 doses of the RNA vaccines.
So the vaccines were listed, and most of them, I can go back to that slide if you want, or you can just email me and I'll give you my slides. And you can also see them, I think, on the registry. So most of those people got the Pfizer or Moderna and had 2 doses. Of course, there was one that got J&J and of course had 1 dose. The couple that were less than 2 weeks from their vaccinations, we don't know if that was 1 or 2 on those 2.
And on that same slide you were referring to, and it said there like 2 months out, that's 2 months out from the second vaccine.
Yeah, or greater, it was basically greater than 2 weeks up or even 2 months out, yeah.
Yeah. And then Dr. Rapovich says, do you ever test for anti-SAR, anti-COVID antibodies in your clinic? And if so, when?
So I think that is not recommended. I've never heard it be recommended on any, speaking to virologists and that's sort of, but that said, yes, I have done it. In people who are extremely worried about their vaccine response, typically in people who were on a S1P receptor modulator or anti-CD20. And you have to be careful about which test you do, though. You have to make sure to do the one that's anti-spike if you want to know if they had a vaccine response or not. So because at least some of the ones that are available are, anti other parts of the virus. So you, of course, are going to get a negative if the patient has just gotten a vaccine against spike. Quest does have one that you can order that's specifically against the spike.
And I see Dr. Lopez just put in a question about there's a large ascertainment bias. What, if any, conclusions can we draw from the registry giving a large ascertainment bias?
Yeah, I mean, I absolutely 100% agree. And we have, struggled with that. So what we do is we try to compare within the registry itself against different disease modifying therapies. And then I think we've received a little bit of reassurance that we can make some conclusions regarding severity of the disease in certain disease modifying therapy categories based on the fact that we're seeing the same results in a whole bunch of different registries. I didn't even mention the Dutch registry and others that have shown similar results of anti-CD20 people doing a little more poorly. And we're beginning to see results suggesting that beta interferon and glutamine may have people on those may have a better outcome even after adjusting for age and sex and stuff. But agreed that this is not ideal. There is clearly an ascertainment bias in any registry, and we all realize that, and but that's what we have right now, unfortunately.
And, this may be the last question given the time, but Dr. Rapovich says, it may not be a fair question, but do you think a booster, a third dose, will change anything like the percentage of responders?
So I think you're probably referring to the anti-CD20 and S1P receptor modulator folks. And I don't know. I mean, I think after seeing some of the data that's coming out, such as Amit Barower's papers suggesting that if B cells are repleting a little bit, you see a better response. I mean, my thought is that we check B cell repletion, and if there's 2 or 3% there, maybe go ahead and do the third or booster. They're slightly different thing with the patients, and we can then potentially check for antibodies to spike. With S1P receptor modulators, there was a paper pre-pandemic looking at siponimod, which has a very short biological half-life, and they basically, this was for flu vaccine if I remember correctly, and they would take people off siponimod, or they had one group that was taken off siponimod such 7 or 10 days prior to vaccination, vaccinated, one-time vaccine, and then kept off again for another 10 days. And they found a much better response to the vaccination by doing that. Of course, one might run into problems with a rebound of MS activity, but I think you could do that with siponimod and ponesimod because they both have a really short biological half-life. And it's something I've thought about maybe doing, with people.
Yeah. Well, we're at the bottom of the hour, and I just want to thank you again for giving a great talk. And we'll hope to have you out again in person in better times with less COVID around. And then just to remind the attendees, you can claim CME credit. You text or go onto the website and put the code number for the meeting in. So thanks, Ann.
Thank you, Jim, and PQ.
Thank you, Dr. Cross.